fourth, the fifth, 6 months, and
Yeah.
and I will tell people as well, hey, you're not necessarily going to know how good you're going to be until you're a year out, but at a year, year, you pretty much have what you're going to have.
Hi, welcome to the Dr. Gil Show. My guest today is my friend and colleague, Dr. Kurt Bormann. Welcome to the show, Kurt.
Thanks for having me. I'm excited to talk about shoulders.
Yes, Kurt, you are an orthopedic surgeon, board certified, and you did special subspecialty training, like a fellowship in shoulder specifically, right?
Yeah, that's correct.
So after you went to medical school in Iowa, so you're a Hawkeye through and through.
I'm a Hawkeye fan.
That's right.
It's a lot of average years, unfortunately, for football.
It happens.
Yeah.
Now Iowa was for a long time a foe of the University of Michigan, and always a respectable team. But you were born in Iowa, went to medical school in Iowa. Then you did a residency in orthopedic surgery in Nebraska.
Yep.
Not too far. How many years is that? 4 years?
5 years.
5 years. Orthopedic.
In Omaha, and having to listen to the Cornhuskers talk about their football team.
You then did your fellowship in shoulders. So well, first of all, what got you interested in medicine in the first place? Did you know when you were a child you wanted to be a surgeon or a doctor?
I didn't. It's funny when you're in high school and you take the tests that say you should maybe go into this profession or that profession. Thought I was going to go into business or who knows what, and it said you're going to be a physician.
No.
And I thought, no, that's silly, and went to college at Truman State.
Truman State, that's in Missouri.
And
Isn't it?
Up in Kirksville.
In Kirksville. But so you got an MD.
Yeah, so did undergrad at Truman, and probably about third year, just decided that I was in the exercise science program, and so decided that I was trying to decide between physical therapy and medicine, and just thought for whatever reason that I would go the MD route. So applied, and was fortunate to get into the medical school at Iowa, which is where I'm from, and so spent 4 years there, and then decided, after a couple, 2 or 3 years, that I wanted to do orthopedics. So. Now,
it's hard to get orthopedic spots. You must have been an impressive student.
I tell people I've always been about 70th percentile at most tests and most things. So, yeah.
That's good. When you grade on the curve, that's good. So you did orthopedics, and did something about shoulder surgery catch your interest in particular?
Yeah. Once you're in residency, which I was in Omaha, I went through all the different rotations, and I think by third year just determined that was what my interest was compared to any of the other specialties. With shoulder surgery, you have the ability to do arthroplasty or replacements. You can do arthroscopy, which I do for rotator cuff repairs, things like that, and then also fractures. And so there's not all of the specialties really have that to offer, and so I like that variety.
Yeah, it is a tremendous sort of variety, and we're going to go through all that stuff from the smallest to the full joint replacement. I'm really looking forward to learning about that. So you did your fellowship, and you did it in a couple international places. Were you in Germany?
Yeah, that's correct. Once I determined I wanted to go into the shoulder subspecialty, I started the interview process to have a spot here in the United States, and then kind of looked and said, well, I've just been in the Midwest. And so I pulled my name out of that program for the match and determined I was going to find something else. So I looked at New Zealand and was able to get a spot for a fellowship in New Zealand, but that didn't start for about 6 months after my graduation. So then I looked at some traveling fellowships in Europe, and I was able to go to Germany for 4 months and do a couple traveling fellowships in trauma.
Whoa, did you have to speak German?
Just a little bit, getting off the bus and talking to people. Yeah, just a little bit.
A little bit, yeah. A bit means thank you. Yeah, don't even get me started. I know 10 words in German.
Yeah, I've forgotten most of what I learned.
So, specialize in shoulder. And I have a particular interest in shoulder because I've had both my shoulders operated on. They took a little peek in this one. They did a whole reconstruction. And I'll get into the details later as I learn how this is done. I have a tremendous fascination with shoulder. The shoulder is a very complicated joint. I remember as a student learning anatomy, it was like the shoulder was like, oh my God, it can do so many things. It's got to move all these different directions.
Yep.
This way, you got to be able to throw. Apparently, tell me if I'm right, humans are different from apes because we have a teres major that goes across the joint and you can throw. Well, we can throw, whereas apes.
No, I guess I didn't know that about apes. I guess.
Yeah, they don't have a teres major apparently. They have a teres minor, but they don't have the major.
Both,
so we can throw spears. Interesting. So the shoulder is very complicated, and I would love for you to spend a minute now just kind of explaining the shoulder joint so we can know where to start.
Yeah. So you have the humeral head and the glenoid, which are the ball and socket.
All right. So I'm going to translate this to English.
Yeah.
We have the upper arm bone. Here, I'm going to model it for it. The humerus. Arm bone goes up here to a ball.
Yep.
Which goes into a socket. And what did you call the socket?
The socket's called the glenoid.
All right.
That's the medical term. And it's surrounded by a capsule and then the rotator cuff. So a lot of people get confused and they think the rotator cuff is the ball and socket joint. But in fact, it's the muscles and tendons that help with raising the arm and all of our throwing actions like you mentioned. And so that's kind of the major features, but there's also the labrum, which is around the edge of the socket that the capsule joins onto to help with stability.
Okay. So let me further get into this. So we have the humerus, the upper arm bone.
Yeah.
And it'll go forward from the pecs. We'll push it forward. And the lats will pull it down. And the deltoid pulls it up. But there's a whole nother complexity. So we've got these gross motions, but then we have this. And this is rotator cuff, isn't it? These twisty motions. So the head is rotating inside here.
Correct.
And I'll show the camera here. This is the rotator cuff, which attaches to the head,
around the
ball,
edges,
around the edges of the upper humerus. So on the outside of the shoulder here, there's a spine on the shoulder blade. So the muscle above it is the supraspinatus or supraspinatus.
Yeah.
Underneath the spine is the infraspinatus.
Yeah.
Another in the lower part of it here, I believe, is the teres minor.
Correct.
And then on the other side, on the inside, you really can't see it. You can barely even feel it, is the subscapularis.
Yeah.
And then
front rotator cuff.
The front, right. And then I don't mean to be explaining to you.
No, you're doing a great job.
Explain
Keep
for
going.
the audience here. And then there's one more little tendon from the bicep, the long bicep tendon, kind of goes over and also attaches. Is that attached to the glenoid or the labrum?
It attaches to the top of the glenoid. It traverses the joint. There's another tendon in our body in the knee that does the same thing, but it's a bit unique in that fashion that it goes, through the joint itself.
So it's very complicated, and it was described to me in medical school that the tendons hit the top of the humerus like this. You hit the supra, the infra, anyway, it goes around the ball like this, so it can control this rotation.
And it also helps to pull the ball in, the humeral head in, and stabilize it to help the arm go up. So when you have a deficiency that's severe, then you lack that function, and that's important. So yes, the rotation is a component, but also initiating the ability to start raising the arm by pulling that humeral head in.
I see. And dislocation, maybe we'll get into dislocation a little bit when the disc can pop out and tear a few things. And then I just want to also point out that it gets really tight in here underneath the shoulder blade processes, and you've got tendons coming through here and sheaths, these little membranes called bursas and tendons. There's nerves coming through here through tight spots, so nerves can get pinched by spurs and whatnot. So this is so complicated, and that's the total extent of my knowledge. But at least the folks at home can get an idea how complicated this is and why
Better
we
than my
need.
reproductive anatomy.
Yeah, that's right.
Yeah, I would, yeah, so,
So there's an introduction to the shoulder
yeah.
and all the things that can go wrong with it. So does the shoulder just naturally age? As a person gets older, I'm in my 60s now. Is it expected to start getting shoulder pain just from getting old?
Yeah, I tell people that most of the problems come from attrition, so things just slowly wear out. People always come in and say, I hurt my rotator cuff, and I did such and such 2 weeks ago, and I think I tore it. And in fact, the vast majority of those injuries have occurred over time, where things just slowly wear out. And then there may be an event that's sort of the icing on the cake, if you will, to kind of push somebody over the edge. But there's not, the acute injuries are far lesser. It's a much more bigger deal over time, where you start to have arthritic change or tendon tears, that sort of thing.
So what type of activities will wear down your shoulder faster than average?
Well, a lot of people ask me that and say, well, I just, sat at a desk and I did office work, and why is my shoulder arthritic now? And some of it is environmental with, the occupation you have, or if there's been trauma, some maybe an innocuous trauma that people didn't realize. And some of it's genetic. Some people come in and they've had both knees replaced, both hips replaced. Now they're working on their shoulders, arthritis in their spine, things like that. So it's multifaceted. It's so when people ask me that, I can't necessarily say that it's simply from a repetitive use injury, like somebody who works in a factory or something like that, that's doing the same thing over and over. It's not always like that.
Gotcha. Yeah. So it can run in families. Because my daddy had bad shoulders, and I recognize the pain. So when should pain get someone's attention enough to come see a specialist like you?
We all have pains that come and go. You work out in the yard, and you have a shoulder pain that you go to bed with and wake up with and lasts a couple of days. But when people start having pain that's in the same location, it's drawn out over several weeks, I think then it's worth, at least seeing your primary care provider. If not, coming to see one of us at the orthopedic group and letting us, try to figure it out, because a lot of people put things off, especially with shoulders.
Right.
They'll have a pain and they say, I'll deal with it some other time. Hip and knee pain is a bigger deal for people because they're up and walking all the time. And so once their knee starts to hurt, they're walking on it every day. So most people end up with, in terms of replacements, hip and knee replacement prior to shoulder replacement. So a lot of people put things off, and unfortunately, when they do come to see us, sometimes it's substantially worse than what they expected.
Gotcha. So general doctor, maybe for first cut, and if there's anything orthopedic they think needs some help, they go to the Columbia Orthopedic Group. Now, would they necessarily see you, or do you have any of the sports medicine doctors or generalists all be qualified to at least do an initial evaluation?
Yeah. Absolutely. We have, kind of a broad spectrum. We have Ouch Clinic, which is an urgent care that we opened for sports injuries, orthopedic injuries, where people can come in, they hurt their ankle on the weekend, and they want to be seen right away. So that's a new aspect to our group that's been very good for patients. And then from there, we have, as you mentioned, non-operative providers who will see a variety of ailments. And once they've gotten a diagnosis, if they think that perhaps they need surgery, then they will ask one of us in the group to see those patients. But a lot of things can be treated conservatively without surgery.
Sure. And every time I have a surgeon on the podcast, I like to stress there ain't no good surgeon that wants to do unnecessary surgery. We're plenty busy. The last thing we want to do is operate on somebody that doesn't need it and whom we can't help them.
Yeah, I think a lot of folks who come into my office would say that I end up talking a lot of people out of surgery who have been told that, hey, maybe you need a replacement, or you have a bad rotator cuff tear and you need that worked on. And we sit down and talk about their quality of life, what they're able to do, not able to do, how much pain they're in. And so, a lot of folks end up leaving the office and say, well, I'm going to see how this does for a while, and if it gets worse, I'll be back.
Right,
Yeah.
right. That's good to know. Now, when I Googled shoulder pain, I got all these different itises. We got arthritis, bursitis, capsulitis, tendinitis, slap tear, bone spurs, frozen shoulder.
Yeah.
I'm sure we could do hours on that, but can you
Yeah.
give me just some idea what's the difference between arthritis and bursitis and capsulitis, please? Can you explain that?
Well, the most common injury or problem that people have with shoulders is rotator cuff tears. That's the number one problem, if you will, in the older population that I would typically see, older adults. And in fact, with those, we only operate or treat probably 20%. So there's about 80% that we don't see that go untreated. So when somebody comes in to talk to me, I say, well, there's probably thousands of people out in Columbia right now who have that sort of injury, and they just don't know it yet.
Gotcha.
So that means that, yes, if you have a rotator cuff tear, you can live with it. They don't all need surgery. So in my practice, that the rotator cuff tears or tendon tears and arthritis are probably the main ailments, surgeries that I perform. Arthritis is the gradual loss of cartilage in the joint, whether it's your shoulder, or your knee, your hip. And it's a progressive condition where you can start off with mild cartilage loss that we can diagnose arthroscopically or even see on MRI, to the point where you have severe arthritic change where you've gone past the point of cartilage loss and now you're starting to wear away bone, which we unfortunately see a lot, as I mentioned, because sometimes people don't come in right away. And once they get to me, and we're looking at it, I can say, hey, this has been going on for a while, and now we have a little bigger problem, but a lot of people didn't know it, It's pretty amazing.
You just baby it and work around it.
Right.
Interesting. So so that's arthritis. What is bursitis and capsulitis? What are those things?
Well, bursitis is kind of the bursa is sort of a potential space above the rotator cuff and between the rotator cuff and the acromion. And that tissue in there can get inflamed.
This tight spot right in here. Okay.
Yeah. And so some people talk about impingement, which is a condition where you can get abrasion or rubbing from the underside of the acromion here at the top.
This process right here coming off the top of the shoulder blade. Okay.
So that can be, a definite source of pain and inflammation. It's not often that someone just needs a bursectomy, where we go in and remove the bursa. Typically, we will be doing an arthroscopy and see that the bursa is inflamed, hypertrophic, and so we will debride that area, and then oftentimes there is some abrasion or tearing of the rotator cuff, and then we go on to treat that.
Okay. Now, if someone has a bursitis, can you inject steroids or anti-inflammatory compounds?
Yeah, that's probably the mainstay. That's probably the mainstay of treatment. So if somebody has impingement or bursitis, steroid injection and physical therapy is usually the first course of treatment. And can
work and can bring relief. Yeah. What is a frozen shoulder?
Yeah, that is a bit
easy question.
Well, it's not. It's a bit perplexing for patients because I see someone probably every week in clinic who has frozen shoulder, and it's a bit hard to explain. But the immediate lining around the ball and socket joint, that's the capsule. In adhesive capsulitis is the medical term for frozen shoulder, and it most often just happens out of the blue. We don't have an explanation for it. Sometimes there's trauma. Sometimes there are issues with immobility. I've had patients who've had heart surgery, and 2 or 3 weeks later, they get out of the hospital. A month or so later, they come back. They come to me and say, "I don't know what happened, but my shoulder hurts." Folks who are diabetic or have hypothyroidism are predisposed to frozen shoulder, so that can be a major contributor. But essentially, that lining, that capsule gets thickened, and there's a over-proliferation of fibroblasts, a type of cell. So if you took a biopsy of that tissue compared to a normal capsule, you would see that cell line is more abundant.
Yeah.
And so it's about a 12 to 18 month process, I tell people, if it's just left to its own devices. So most people start out with just pain, and they don't really know what happened. They start hurting, and then over time, the stiffness sets in. That's the freezing phase, and that can last months. Okay, and so even in clinic, sometimes we'll have people come in and they'll be in the early phase where they just are hurting, and it's a little bit difficult to diagnose because the stiffness hasn't set in. And then perhaps 2 months later, they come back, and then, now it's stiff, and we can't passively move the arm because that lining is so tight and thickened that it's inhibiting the motion of the ball and socket.
Yeah, fibroblasts are the cells that come into wounds. They're part of a wound, and they lay down collagen and these strong protein bundles, and that's part of normal wound healing, but that's happening in a place you don't want it, I guess.
Right. And so our initial treatment is usually a steroid injection and down into the joint, glenohumeral joint, and then we initiate physical therapy and home stretching. A lot of people can just get better with that and not have to have anything else done. If folks are still struggling 6 to 8 weeks later, then we'll discuss the manipulation, which means we put you to sleep for 5 minutes and break it loose.
Break it up.
And so when we tell people that, they usually kind of, their eyes wide, and they don't necessarily want that, but it's effective.
Interesting.
So we do that, and I tell people it's sort of like hitting the fast forward button. People continue to have some stiffness after that, but most of the time we can push people along and get relief sooner than if it was just, if it went untreated.
Gotcha.
So it's, but it can be difficult for patients to grasp exactly what's, what it is and what caused it. And sometimes, as I mentioned, we just don't have a good explanation.
And did I hear you right? You said it's about a 6-month process till you kind of get over, or a year?
Yeah, 12 to 18 months.
A year and a half even till you're kind of the normal arc.
Yeah. So there's the freezing and frozen, and then the thawing, we call it, where range of motion starts to come back.
The thawing. Interesting. Now, I also understand that sometimes pain that you feel in your shoulder is not really coming from your shoulder.
Yeah.
So that must be confusing. So where might shoulder pain be coming from?
Yeah. So I see, again, probably someone every week or every other week who has shoulder pain, and it's coming from the cervical spine.
The spine and the neck. Yeah. So the nerves for this area come out between the 5th and the 6th vertebrae and thereabouts?
Yeah. For some of the muscles. So they innervate the muscles, and some people will have pain if those nerve roots are pinched. Some people have motor deficits and weakness. And so that...
Motor meaning the muscle, the strength of the muscle, they're weakened.
So that is a bit difficult to tease out. And so a lot of times we're doing a process of elimination. What is, is it your shoulder intrinsically having a problem, or is this something that's referred from a pinched nerve root? So we have to figure that out quite frequently and try to. And some people can have two problems. I call it having ticks and fleas.
Ticks and fleas. Oh, can I borrow that?
You can borrow that.
I tell people that all the time. Ma'am, sir, it's more than just what you thought.
Yeah, and so we will, get additional imaging of the cervical spine, get nerve tests if we need it. A lot of times I'm referring folks to my spine partners and having them take the ball and run with it. And sometimes we get those issues addressed, and then they come back to me, and we proceed with treating their shoulder.
Gotcha. So you can't just rush in and assume anything. You're thorough, proper.
It is, because some of the surgeries that I do can be greatly impacted by nerve, deficits, motor deficits from nerves that are pinched. And if you don't pick it up, it can have implications for how well people do after their shoulder surgery.
Makes sense. Yeah.
So,
are there any particular injuries that you see that are the most common that cause these shoulder injuries, the damage, pain, tears?
Yeah, I mean, people, as I mentioned earlier, the icing on the cake is a lot of times it is lifting, it is, or falls, sudden movements. Somebody will have, they'll try to catch themselves and they'll feel a pop in their shoulder.
Yeah.
Or they'll, have actual falls and injure their shoulder, which is a whole nother aspect when we get to fractures and things like that. But yeah, it's a lot of times that's what brings somebody in, and that's when I have to say, hey, this was a pre-existing problem, but you did something to kind of finish it off. Sometimes young people can have significant injuries, acute rotator cuff tears, for instance, or dislocations and injuries to their labrum and capsule. So those are obviously more violent, more traumatic injuries. So it's a broad spectrum. Young people, have typically different problems than older adults and elderly.
Yeah, Hunter was just at a wrestling competition with this young man who unfortunately keeps dislocating his poor shoulder.
Yeah.
And so let's talk about shoulder dislocation. How do you know your shoulder's dislocated?
It
hurts like hell, right?
It hurts like hell.
All right.
You can usually see a deformity, have trouble raising your arm. Some people, sometimes when they dislocate, they'll spontaneously reduce. I actually see quite a few people who have that.
They'll pop out, then pop in.
Yeah.
Okay.
But then other people have to come to the emergency room and have it put, reduced under or put back in under some anesthetic. We drift them off to sleep so we can get it to go back in, and then we have to deal with the sequelae of that. For older folks, when that happens, a lot of times they don't continue to dislocate. Essentially, the younger you are when it happens, the more likely you are to have repeat dislocations. Each decade, as you get older, it's much less likely you're going to have repeat dislocations. More likely that you will have, in conjunction with the dislocation, a rotator cuff tear. So we'll often see that if we have a 70-year-old or 80-year-old who has a fall and a dislocation. The ball, the humeral head may spontaneously reduce, or we put it back in, but then we find that they have rotator cuff tearing. So it's the pathology changes. In young people, it's an issue, injury to the labrum and the capsule. Sometimes you start to lose bone, and that makes it more complicated.
Seems to me when that ball comes out, it's got to tear something.
Yeah. And I deal, I don't deal as much in the younger population. A lot of my sports medicine partners treat instability. For me, a lot of times when people are older, we see folks who have had chronic dislocations. Their shoulder's been dislocated for months.
It stays dislocated.
Right. And then we're talking about shoulder replacement. So it's a broad spectrum, and a lot of it has to do with how old you are. If you're younger, you have repeat dislocations. Well, surgery's on the table to determine what needs to be repaired, and there's various surgeries to take care of that problem, and a lot of it has to do with how many times you've dislocated, what activities you're involved in. If you're an athlete, you play football. I'm
thinking about this young wrestler, very talented young wrestler, but keeps dislocating. Could there be a surgery to tighten it up and make it less prone?
Yeah. So the first line of treatment is usually repair the labrum that's torn, repair the capsule, see if that's going to.
So that you can do that.
Yeah, absolutely. That's I would say the majority. That's the solution. But for people who keep dislocating or start to lose bone on the socket, then you have to get to more involved procedures to provide stability, and especially in people who are involved in violent sports, sometimes you have to go to that more extreme measure. Where we're doing actual transfers of bone in the shoulder to help with stability. So, so
that sounds complicated.
It is. And a lot of my sports medicine partners, that's, a lot of what they do when it comes to shoulder surgery, in addition to rotator cuff.
They do it too.
Oh, yeah.
So it's not just Kurt doing the shoulder. The other surgeons are very qualified as well.
Yeah. All of my sports medicine partners do a great job with instability and the other issues that I treat, like the rotator cuff tears.
Okay, now I don't want to give specific medical advice, but you got to tell me. You're out, you're miles from home, you're out in the middle of nowhere, your buddy dislocates his shoulder. What is the move? Is it external rotate, pull down? What is the stereotypical move to pop it back in?
Yeah, when I reduce the shoulder, it helps if you have someone giving you resistance from the other side of the body, whether it's with a
all right. So we got three guys now in the middle of nowhere.
You have the injured person, and then if you have another person, that's helpful. But a lot of times it's traction, pulling down on the arm with gentle internal and external rotation.
Okay, rotate it a little bit,
and then I'll actually try to find the humeral head that's prominent here. And
it's here.
Oh, yeah, yeah. So it's most of the dislocations.
It goes forward. Yeah. Oh, I thought it would go down this way.
Most of them are anterior. Posterior dislocations occur in seizures, and people get electrocuted. So things like that will make it dislocate posteriorly. So the vast majority are anterior. So it's up here. You're able to typically palpate, feel where that humeral head is.
Okay.
Traction, some gentle internal and external rotation, and usually a little bit of manipulation.
And push that sucker back in.
Yeah.
That can be done.
There's lots of different, historically, lots of different ways that people do it, and that's just how I do it. But
so it's going forward here. This is the subscap. So this is the collarbone here. So it would go this way.
Nestled underneath there, yeah.
Okay. All right. Don't do this at home. I just wanted to know.
Yeah.
Asking for a friend.
Definitely would give it a try in the wilderness.
Yeah.
And if not, then pat them on the back and hike it out to wherever you got to go to
right.
get some sedation.
Gotcha. So, if someone has failed conservative measures, injections. Now, there's physical therapy, right? You have a whole physical therapy department, don't you? There's things you can do to help shoulders, aren't there?
Yeah. I mean, when you're speaking about the rotator cuff tears, studies will show that in the short term, if somebody has, just say, an average rotator cuff tear, which would be like your supraspinatus, which is the most commonly torn, steroid injection with physical therapy in the short term, maybe even up to a year or two, can provide as much relief as surgery. Okay, so a lot of folks, and even longer term studies will show that people can do pretty well leaving the rotator cuff torn and just trying to treat the symptoms. What I tell people is, after a couple of years, if there's two groups, folks who've treated it conservatively versus folks who've had it repaired, typically once you get 2 to 3 years out, those folks who have had it repaired and get it to heal do better. But in the short term, the studies would show that the outcomes are similar.
Yeah, having had my supra put back on it hurts like the dickens.
Yeah.
For weeks and weeks afterward. Yeah. They say, folks, when they tell you it'll be better in 6 weeks, don't believe them. It's like 6 months to a year.
Yeah.
At least it was for me.
I tell folks the bulk of it's in the first 3 months. We immobilize people for 6 weeks, but getting to that 3-month point is a big hurdle when it comes to most of what I do, whether it's rotator cuff repairs or replacements or fracture treatment. So, yeah. But you're right. You get better the 4th, the 5th, 6 months. And I will tell people as well, hey, you're not necessarily going to know how good you're going to be until you're a year out. But at a year, year, you pretty much have what you're going to have.
Gotcha. So by the time someone comes to you, the shoulder surgery specialist, they've probably had a pretty good diagnosis. They've probably had the physical therapy, the injections. By the way, do you ever inject platelet-rich plasma into various things? I know that's controversial. We're starting to use it in reproductive medicine, believe it or not.
Yeah, I'm actually going to have my lateral epicondyle. I'm going to get that done for some tennis elbow I've been dealing with. But, some of my non-operative partners do that on a regular basis. A lot of it will help with inflammation. Studies will show that. It's difficult to say that it's going to necessarily heal. It won't heal a full thickness rotator cuff tear. Okay?
Yeah, if it's shorn off, that ain't fixing that.
No.
But a partial tear might get in there and
right. It can be beneficial. I think that a lot of it is the anti-inflammatory properties. So stem cells, people try those things, and again, it's not going to help regenerate cartilage. It's not going to regenerate tendon. It'd be nice if it would, but we're not at that point.
Not yet.
Yeah.
Maybe some genetic engineering and stuff is in the works.
Yeah, I mean, you can even grow cartilage in the lab. A lot of my sports medicine partners will have that done for knee surgery. So if you have a localized area of cartilage loss, you can have some new cartilage grown and put it in. And
your own cartilage, like your own genetics?
So, yeah.
They can do
or
that?
Our allograft, where it's, you have from other folks. So we do quite a bit of work with allografts that are.
What does
donors.
allograft mean?
Allograft means it's donor tissue. So someone who just like somebody who donates their organs, they donate other parts that we use in orthopedics.
So a deceased person can donate cartilage.
Yeah, it's that more often we're doing things with dermal allograft where we're using skin that's processed and it's almost like leather. That's what, in my practice, that's what we do more frequently.
Fascinating. So you have a diagnosis. Looks like surgery might be a good option. How does Kurt Bormann evaluate the surgeon? How do you determine what you're going to do? So I guess let's talk about the range of things you can do. So they've tried the injections, doesn't work. You're now going to do surgery. The least invasive is an arthroscopy or a telescope in the shoulder.
Yeah. So
what is that about?
So you come in, you go to sleep just like any other surgery, and we make poke holes in the shoulder and have a small camera that we insert, and we can do that for diagnostic purposes, and then we proceed from there for therapeutic.
So when repairs. You look in, are you looking in the capsule or are you looking in the various spaces?
Spaces, yeah. So you're looking in the glenohumeral joint to begin with, and you look at the cartilage, look at the rotator cuff tendons from the underside.
So you can see the actual tendons.
Yeah. Yep.
And identify them.
So that's the first thing we do. We look around and we see, what each of those structures looks like. We match that with what we've seen clinically and what we've seen on imaging, and then proceed from there.
That's something I should have talked about more. Imaging, is MRI pretty much what you do? Is that the most accurate imaging, or plain X-rays? Is there much of a role just plain X-rays nowadays?
Yeah. Plain X-rays is the first imaging study.
Okay.
We determine, in my practice, do you have arthritic change? If you have arthritic change, then that's usually the main problem, but you can, as we said earlier, have more than one problem. You can have tendon tears, so it's a combination. For soft tissues, when you're talking about tendons, labrum, those things, the capsule, then the MRI is more helpful, yes. So then like I said, we determine, okay, you have a rotator cuff tear based on the MRI, based on the clinical exam, go to the operating room, proceed with a repair.
So you've got an idea usually when you go in, probably what you're going to find.
Typically, and I will say to people, hey, 10% of the time it's probably worse or not as bad as what I expected, and so get in, and sometimes we look at everything and say, oh, this is a lot worse than we expected, and then a little more involved surgery.
So to do a survey, what is that? That's 3 little holes in the shoulder, or 1 or 2? Several.
Yeah. 4, 5, 6, 7.
I think I've got 4.
Whatever it takes to get the job done. Yeah.
Gotcha. Yeah, I'm doing one tomorrow morning. I'll probably end up putting where I need them.
So, and each physician, each surgeon has, their different nuances of how they go about it, and we call them portals, and which portals they use, and has to do with your training and what you do in your practice over time. And
I've noticed
you're familiar with.
If you look at a lot of folks get gallbladder surgery. Yeah. It seems every surgeon has their own little pattern of where they put the little hole. They're generally in this area.
You're right, exactly.
Right. So you put the arthroscope in there, and let's go for a common injury. There's a rotator cuff tear. How do you fix such a thing?
Well, you look at the tear pattern, which first of all you determine which tendon is torn. So it's
because
there's 3 that we most commonly are dealing with is the subscapularis in the front.
This one right here.
Yeah. And then the next over, the supraspinatus is this
bad boy right here.
Most commonly torn.
Most commonly right here right there at the cuff.
Yep, at the insertion, and then you work your way back. Most people don't have teres minor tears. I mean, they can, but it's relatively infrequent.
Okay.
So you determine which structures are torn, the tear pattern. Are they just torn away from bone? Do you have some tendon left attached to the bone and you've torn in the mid-substance? Do you have delamination where the layers have split? So it gets to be a little, you have to identify how it tore to put it back as close to you can in an anatomical way. So
So what types of things would you do for these various tears?
The main
Stitches, posts, shark hooks. Well, what do you do?
So for the vast majority of the tears, we are putting anchors in the bone. Made of, either biocomposite, where it's calcium based, and those anchors will absorb over time. We use a plastic anchor has kind of been the mainstay for lots of years. Probably
Is that fairly permanent?
Yeah, permanent. It's a peak anchor, polyethyl ether ketone.
Yeah.
Prior to that, there was metal anchors, so it's kind of evolved. Now we use anchors that are all suture, okay, and they have devices that secure them. You put them in the bone and you tighten them up, and it's just all suture.
It's pre-made. It's like a jig almost.
Yeah. So there's been an evolution. But essentially, those anchors have sutures that come up and out of them, and those are the sutures that we pass through the tendon and to reattach it to the bone.
So you can go in there and stitch it as if it were open, but do it through these tiny holes.
Yeah, and open repair is still done. If someone has a massive tear, for instance, of their front rotator cuff tendon, I'll frequently, if I think I can do a better job open, we'll make an incision and look at it with our own eyes rather than the camera. So. You just want to do the best job you can, whether that's arthroscopic or open. And I think patients appreciate that. They don't mind a bigger scar if you have to have it.
You get your shoulder back.
Yeah.
So that's, once again, the experience that you have to make that judgment, how you can do it.
Yeah, it's, some people wake up and they've got a bigger whack on their shoulder than they expected, but, incisions heal from side to side, not top to bottom.
Ah, that's right.
Yeah.
That's right. And hopefully your patients knew this before they went to sleep.
Yeah.
So you can repair a lot of these things. Can sometimes you have bone spurs here, tightening things up?
You can.
What can you do about that?
We have little burrs that we insert, and high-speed burrs that
power grinders.
Absolutely, and
power
grind
tools
that away. And those are often part of the pathology of the rotator cuff tear, but not always. As I mentioned, it can just be attrition. There's been debate over the years about the involvement of spurs in rotator cuff tears, and I think it can contribute certainly, but not always. So then that's also something that you assess. Not everybody has a bone spur that they need to have removed. A lot of patients will say, I got this spur. Well, we'll look and see when we're in there, and if that looks like it's abrading, causing the tear, of course, we'll deal with it, but not always.
Now, you mentioned you can have shoulder fractures. I'm sure car wrecks, sports injuries and stuff. Where in here do you see fractures and breaks of the bone?
Yeah, this time of year, people fall out of deer stands and things like that.
Yes. Yeah, there are two state-sanctioned sports in Missouri.
Yeah.
River floating in the summer and deer hunting in the fall.
Yeah, it seems like everybody does, but me.
Yeah, it's like a religion. I understand it. It's a lot of fun, part of the culture.
So, I would say, virtually any part of the humerus can fracture. You can fracture the shaft, that comes down, or up in the ball, which is what I end up dealing with quite often.
So you have a fractured ball. What do you do? Do little screws or rods, or
a lot of times it's
metallic replacements?
That's
we're going to get to that, by the way.
Yeah. Some vast majority, again, kind of the 80%, 20%, vast majority of those where it's the humerus we treat non-operatively. So they will heal. Sometimes they frequently are healed in a malunited position, not the way God made you.
Right.
And people still do just fine. So we try to treat as many of them non-operatively as we can. And then, but there's a whole, how things fracture, the humerus fractures. My trauma partner, Dr. Robertson, fixes the majority of those that need plate and screws.
He has promised to come on the show, by the way. Mike, if you're listening, you're not off the hook.
Yeah, he does a great job. So clavicle fractures are common. People, doing mountain biking. They
go over the shoulder blade right here, the clavicle.
They go over their handlebars. They hit their shoulder on the ground.
Easy to snap.
You can have scapular fractures. Oftentimes those are a bit more dramatic, but those also heal pretty well non-operatively because of all these muscles around the scapula. So, and when it gets in terms of what I deal with, it typically is involving replacement because of the fracture is too severe, or we try to put it back together with a plate and screws, and that doesn't work, and then we move on to a replacement.
All right, which leads me to the penultimate topic here, because this is what you're really known for.
Yeah.
When do you give up on this shoulder and go to a shoulder replacement? So when does that come? I know a lot of your patients are older.
Yeah.
So talk to me about shoulder replacement in general, Kurt.
Yeah. Yeah, that's the most common thing that I do now. It's kind of evolved over the years, but that's the bulk of my practice. Yeah, so we see lots of folks with wear and tear, osteoarthritis of their shoulder, the glenohumeral joint. Some folks with rheumatoid arthritis, but that's being treated medically, more medical treatment now. But we still see a fair number of folks who need a replacement for that issue. So yeah, we assess, as I mentioned earlier, we figure out what's your quality of life. How much pain do you have? Does it hurt every day? You have pain at night? Are you able to do the things that you want to do and need to do from a functional standpoint?
Right.
And
can you eat? Can you toilet? Can you drive?
Yeah. And can you do the recreational activities that you want?
Right.
And so that goes back to a lot of times people come in and they say, well, it hurts, but I'm not ready for a replacement. And so we do the conservative measures.
Mm-hmm.
A lot of times we start with anti-inflammatory medication, then move up to steroid injections, and then finally replacement. So
what determines when you're done? You say, Mrs. Smith, I can't fix this anymore. We got to go for a new joint. When does that decision, or what makes that decision?
Well, the vast majority of people have complete cartilage loss and get to essentially where it's bone on bone, the humeral head and the glenoid.
All right, can't fix that.
Yeah, but even a lot of people, younger, let's say folks in their 40s and 50s, can have just full thickness cartilage loss where they haven't really gotten to the point where it's bone on bone that you can just see in an X-ray and hold it up to a third grader and say what's not right here. You know what I mean? And so, and a lot of those people still need to have replacements as well if the conservative measures have failed. So there is a bit of a spectrum, but yes, most folks get to a point where it's bone on bone arthritis, decreased range of motion, lots of snap, crackle, pop, and it's those two issues. It's your function and your pain. And everybody gets to a certain point where they wave the white flag and say, okay, I've had enough. I got to do it. So then we have to determine what kind of replacement you're going to have. We have to assess how much wear you have, because a lot of folks, as we talked about, don't come in right away. And they've started to wear bone away from the socket, the glenoid. Okay. And that's an issue. Some patients have in conjunction rotator cuff tears. And so nowadays, we have essentially two types of replacement. There's a third, anatomic replacement, where you have a new metal ball, new plastic socket.
Can you show that?
Yeah,
it looks
sure.
like you might have that here.
Yeah. So this is a plastic model of the humerus. So with an anatomic replacement, you have a new metal ball.
Okay.
With varying types of stems that go inside the bone.
Almost like a hip replacement here.
Yeah.
Pop it off, put down a rod, and it's got a new ball on it.
And
can I see this?
And that's evolved over time. The rods the stems, we call them, used to be very long, and just over the years they've gotten progressively shorter to the point where a lot of surgeons use stemless replacements. So it's just essentially a ball with a small, very small stem that goes in to support it.
Into here. So this is a short stem here?
Shorter. That's not the shortest that's available by any means, but
shorter, but it doesn't have to go all the way down here.
Not unless you have other major problems that we have to handle.
Gotcha. So I can see it's got these ridges here, and it's a little rough.
Yeah, each manufacturer, there has to be a way for it to get fixation and stay put in the bone, and so each manufacturer has their own unique way of doing that. Something that the bone's going to sometimes even grow onto to keep it stable.
So I got to know the gory details. What do you cut and how do you do it to pop this bad boy out so you can put this on here?
Yeah.
Gross me out. Go ahead.
So yeah, it's my approach is the delta pectoral or anterior approach is the most common. So
Just an incision here?
Yep, right here across, crescent shaped, about 4 or 5 inches.
Okay.
You're spreading these outer muscles, the deltoid and the pec. There's an interval there that you follow. You get that all opened up, then you get down to the front of the shoulder where you have that front rotator cuff tendon, the subscapularis, and the biceps running next to it. You have to pick whichever way you want to detach that front tendon, swing it open like a door.
So you do have to cut a tendon.
Yeah. So that's
all right.
That's different than knee replacement, especially hip replacement. There is some tendons that you do have to take down that most surgeons will reattach. But with this, it's not only a replacement, but in the end, it's essentially a rotator cuff repair because you have to get that tendon to heal.
I figured you got to get in here somehow.
Yeah. People have tried different techniques of leaving that tendon intact and still getting access. I've been involved in some of the projects on that, and it's pretty difficult. So
big incision, you have to cut some of this rotator cuff. Now I can see how you get to the ball.
Yeah. So you swing that open. You take down some of the capsule. You have to take some of that down, which is also helping hold it in position. Then, yes, you extend and externally rotate, and it pops out like a periscope.
Pop like that.
Yep.
Okay.
And that's
now
how
I
you
can
get
see
to
you get
it
it. Now the power tools come out.
Yeah, saws and mallets.
I won't do the sounds, but it is.
Yeah.
It's power tool sounds. Yeah.
So we take the top of the humeral head off,
Uh-huh.
and we get our exposure to the glenoid, to the socket, and that that's one of the difficult parts of the surgery is getting down there, getting the exposure to the glenoid. And if we're doing an anatomic replacement, that means new metal ball. There is another product on the market that's slightly different material, pyrocarbon, which you don't use as often. Most of the time, it's a metal and then a new plastic socket, essentially.
And a new socket, just like in a hip as well.
Yeah.
Will you ream it now for hips? I remember it looks like a round cheese grater.
Thing. Yeah, cheese grater.
And it reestablishes around, and then you put the socket in.
Yeah, and so there's different types for an anatomic replacement.
Oh, is this one of the
this is a
bases?
It's
oh, look at that.
That's the traditional all poly, we call it, polyethylene glenoid component.
It looks kind of small. It doesn't look like the whole cup.
We have different sizes.
Is the cup bigger?
We have different sizes for everybody.
Okay.
And there's different variations of that. Some of them have metal on the back, metal posts that grow into the bone, which is what we use most of the time now.
Okay.
So that's a little older model of what goes in the socket.
But this is the basic idea.
Yep.
Replace it, put the tendons back together, make it nice and tight, and
and that is what we do if the socket, the glenoid, doesn't have substantial wear, and if the rotator cuff tendons are intact. And then we go on to the next most common surgery, or the more common surgery, which is reverse replacement.
Reverse replacement. Yeah. So let's get to that in a second. So
Sure.
So the person has had this surgery. Do they spend the night in the hospital?
Used to. For a good portion of my practice, it was all inpatient. People would spend a night or 2 nights. Now the majority of them are outpatient.
They stick the insurance. So you can do this surgery, and they would go home that day.
Mm-hmm.
Now, do they have like regional blocks? They got their nerves blocked and
numb up the arm, which lasts 15 to 24 hours usually. And
cut.
Yeah.
Okay. And how long does something like this take to heal? Weeks and weeks?
That's the 3 months process, because we need that front rotator cuff tendon to heal. That's probably the most important part when it comes to an anatomic replacement, is getting that front tendon to heal, which is, I usually explain to patients, hey, these first 6 to 8 weeks, you have to really behave and not be reaching and raising, pushing, pulling, so that we can get that tendon to heal. If we can get the tendon to heal and not have a stiff shoulder when we're done, that's a good outcome.
That's a good outcome. Now, would you be in one of those slings, those fancy slings, for a while with this type of surgery?
A standard sling for 3 to 4 weeks is what I do.
Okay.
Physical therapy is involved, so that was for my practice starts at the end of week 3, beginning of week 4, and they start working on stretching so that we don't have stiffness, or as little stiffness as we can have as our final outcome.
And what kind of results? If you've chosen the patient right, you've done the surgery right, they heal well, Is their pain much improved?
Yeah,
or?
I mean, most people are close to, if not pain-free. Not everybody, but the vast majority. And range of motion also varies. Sometimes that's predicated on how much stiffness you had before the surgery. So if you had a painful shoulder that had full range of motion, then most of those patients get pretty much close to full range of motion back. If you're only able to raise your arm to 90 degrees before surgery, and if straight up is normal, sometimes people get, I usually say, halfway in between there in terms of what your expectation can be. Some people, certainly get more range, but in general, yes, there's improvement in range of motion and less pain.
Most people are happy.
Yeah,
better than they were. That's what we want. We want to be happy and less pain. So excellent. So you might not be a major league pitcher again, but you can drive.
Yeah.
Things off the. I don't know why this is the example. Everybody talks about getting something off the shelf in the grocery store. That seems to be like a standard, a benchmark for arm mobility.
Yeah. Can they do their hair? Can they comb their hair?
Right. Can you brush your teeth? That
yeah.
kind of stuff.
But people want to get back to lots of different things. I have people who want to get back to heavy weightlifting. And we have to talk about that. A lot of people want to be able to golf, and so. Yeah. There's, we have to have a discussion about what to do and what not to do, and what the recommendations are to try to not overdo it, because it's not the way God made you. It's new parts, and sometimes they wear out. So
right. So this is anatomical. Where there was a ball, where there was a socket, there was a socket. Mm-hmm. Now somebody came up with some brilliant idea to reverse this. Mm-hmm. So could you tell us when did this innovation occur? Tell us a little bit of the story of reversing the ball in the socket. Could you tell us the story of this?
It started about 25 or 30 years ago in France. And they, even before that, there's been attempts made, but the current design and what we've evolved from started in France about 25 years ago. Reverse shoulder replacement started in the United States in about 2004, and has become the most common type of arthroplasty or replacement. Really?
So this is now more common than this?
Correct. Yeah.
Fascinating. So what are the benefits of this reverse?
It came into being to treat massive irreparable rotator cuff tears and what we call pseudoparalysis, meaning if let's say you have 2 or 3 or even 4 of the rotator cuff tendons torn and you're no longer able to raise your arm, so your deltoid muscle is working but the rotator cuff muscles and tendons aren't attached, and those are important to initiate the elevation. And so if those are completely torn, it's called pseudoparalysis, where you can't raise your arm. You can take your other hand to raise it up, and it'll stay there.
Okay.
And that's what it was intended for. But it has now, taken a life of its own, and is used for standard arthritis, like we mentioned earlier, for fractures.
So you could go straight to this now.
Yeah, some surgeons, that's the only type of replacement that they do. So
they're getting very
colleagues,
good.
Yeah.
So technically, when you're doing this, are there advantages? Is it easier to put a convex ball in rather than?
Yeah. So with this,
than a cup.
Yeah, the ball, if you will, is now on the socket side. So
right.
It's flipped around, and the cup, the socket is on the arm side. And when you do that, you give the deltoid out here a mechanical advantage to raise the arm. So you give it a mechanical advantage. Usually it's lengthened slightly, and you're providing stability so that the ball doesn't just slide in there. When you have no rotator cuff tendons and you try to raise your arm, instead of the humeral head rotating, it'll also translate. So as you try to raise, it goes like this when it's not supposed to. And when folks come in and it's been going on for a while, on their x-ray, the ball will be sitting up here, and that'll tell you, okay, we've got a bigger problem. But when you flip this around, you're providing stability. So now it's like this, the cup's over here, and it's stable.
So when the deltoid engages to pull this up, it's not. I see. It's actually pushing against this.
Yeah.
Oh, I can see how that would be more stable.
Yeah.
And then once it started, then you're okay. And you can put the now. What's holding this together? You tighten up the rotator cuff and repair it all around.
So it's intended for irreparable rotator cuff tears. So that's how it started. So that in a situation where we can't pull them back over anymore and reattach them. Nowadays, let's say somebody has bad arthritis and the surgeon elects to do a reverse replacement for whatever reason. If the rotator cuff tendons are still attached when it's all said and done, those patients usually do have a better outcome compared to someone who is rotator cuff deficient and the tendons are shot. So if we can repair, especially as I mentioned, we have to detach the front rotator cuff tendon to get in there.
So you do that the same?
Yeah.
That would be the same. Okay.
But sometimes that tendon's gone. It's shot, and we don't have, you get down there and it's gone and you're part of the job is done for you.
Gotcha.
But if we can repair it at the end or some of the other tendons, then studies would show that those patients will do better.
So even without the rotator cuff tendons holding this in, it'll stay in place?
Yeah, most of it's deltoid tension. So as I mentioned,
Okay.
that's a significant part of it. But they can, unfortunately, it's like an artificial hip. They can dislocate. So and especially for men, that's probably the most common complication. So before surgery, I'm having a discussion. For men, it's probably a 5% risk of once we get to the point of raising the arm up and down that it can dislocate.
It can dislocate.
Not as common for women, but it can happen for women as well. But it's a good solution to bad problems.
Gotcha. So you can expect a fair return to normal activities. You can drive.
Yeah, and
can you golf?
Yeah, people golf.
More important, can you fly fish?
Oh, yeah.
There you go.
People swim.
And you swim.
And I get people who want to get back to heavy weightlifting, as I mentioned. I try to talk them out of it, but sometimes that happens.
Well, with my shoulder, I have realized I have to cut down on the heavy weightlifting.
Not benching 500 pounds.
Not anymore.
No.
Not even on a good day. Anyway, so this is fascinating. So this has evolved over the past 20 years, and you're fully trained in this, and you do a lot of these, don't you?
Yeah, we do.
What's a busy day for you? 3 of these? 4 of these?
Yeah, most often it's 4, I would say.
You can do 4 of these in a day?
Yeah.
Wow.
And I mean, there are guys around the country that can do more than that, but that's a good day for me.
That sounds like a good day to me.
Sometimes 5, but that's a pretty tired day to do 5.
Yeah, that's a long day. So how many of these have you done? Hundreds?
Thousands.
Thousands.
Mm-hmm.
That's what you want, folks. Somebody who does thousands.
We do about 350 replacements a year.
A year.
Mm-hmm.
Okay. That's what you want. And do you see this continuing to evolve? Do you see much more room for improvement, or is this pretty optimized now?
It is evolving as we speak. There's some would say that part of shoulder arthroplasty in general is more of the wild west yet, because it is evolving. In terms of what are the best constructs. There's lots of different opinions on. There's a lot of variables to putting those parts in, the sizes, the positions, and there's a lot of different camps around the country as to what's best. And we're collectively trying to figure out what is the optimal construct for hips and knees. That's largely been established for a long time, and that's part of the difficulty with reverse shoulder replacement, because it's not anatomic, and it's a bit of an art, honestly. I think to assess what is the best construct for this person, someone who's a large, strong man versus a small, delicate woman.
Right.
If someone's obese, if they're thin, there's a lot of variables, and so I think it certainly is evolving, and it's I think eventually, probably towards the end, I would guess, of my practice, it'll probably be figured out that this variable, this variable, this variable should be done a certain way. I would expect, because I think we are seeing improvements and seeing what has worked and what doesn't work. But you can go from my practice to somebody in St. Louis or somebody in Kansas City or wherever, and you'll get, someone has a different theory about how it should be done when you get down to the specifics.
The art of medicine.
Yeah.
Well, Kurt, this has been tremendous, just fascinating for me. And as we wrap this up, is there anything about the shoulder that I've not covered? Do you have advice for people? What would be your closing thoughts about shoulder and shoulder surgery?
Yeah. Don't fall out of your deer stand and fracture. I mean, we get a lot of people with falls, and so that's the other part that we have to deal with, the fractures. We get fractures around these implants.
That must be a mess.
It gets blown up, and we have to try to put it back together. Dr. Robertson or myself trying to figure out what to do. I would say, if you do start having pain, it's probably better to get it looked at before it gets to the point where I say to you, well, I would have liked to have done the anatomic replacement, but it's been 5 years, it's been 10 years, and now we're at a point where we're moving on to the reverse replacement, and there's things can, get extremely worn out, and then we're looking at different measures, more complicated types of replacements, different parts essentially. So see your primary provider, see one of us, see one of my non-operative providers, get it looked at. A lot of times, that's probably the majority of the time, it doesn't need surgery right away. So conservative measures, seeing your physical therapist, that'll frequently take care of the problem.
And also make a plug for your group. You have specialists and providers of all the different sorts of therapies and pain and therapy and all that stuff. So we have it's called a multidisciplinary approach. When you have all these experts to come to bear on a problem, usually it does better, doesn't it?
Yeah. I can, if I'm looking at a rotator cuff tear and I'm not so sure about some aspect of it, I can walk down the hall and meet with one of my sports medicine partners and say, hey, take a look at this, or hey, I think you might be better suited to deal with this problem. You do more of this than I do, that kind of thing.
Right.
And so there is a lot of, going from one provider to another to try to get the best outcome. Our group is full of surgeons that are well trained, a lot of experience, and subspecialized. Yeah. And we're constantly growing and evolving as a practice.
Good for you. So, Kurt, I want to thank you so much for your time today. Thanks for being such a wonderful friend and colleague. I really appreciate you coming here and helping educate our viewers on this fascinating topic of shoulder surgery.
Thank you for having me. I appreciate it.
Thank you, Kurt.
All right. Yeah.